Welcome to my YouTube channel, Everything Medical. Today's video, we shall be looking at the anatomy of the lungs or the pulmon. The lungs is a vital thoracic structure. So as we proceed on the class, we are going to be revealing all the anatomical concepts about the lungs. Get. So if you are coming across to my channel at the first time, remember to subscribe so that you get notification when I upload video on human anatomy. Endeavor to share across. Now let's proceed. The first thing we're going to be noting down is the introduction. The introduction. What is lungs? You get. The lungs is a spongy textured organ. It's a spongy textured organ that is known as the principal or the primary organ of respiration. It is a spongy textured organ that is principally known as the primary organ of respiration. You recall that they are always paired on the thoracic cavity. So that is the concept of the lungs. A spongy textured organ that is principally so it is a spongy textured organ that is principally known as the primary organ of respiration. That is the concept of the lungs. You get. And this diagram here shows us everything that we'll be discussing on the lungs, although the medial surface, you get, is not seen here. That is the vertebral surface, and is only some part of the mediastinal surface is seen on this aspect, but all the features are here, you get, except the lung hilum and the root of the lungs. You get. So let's proceed. So this is the introduction. The spongy textured organ that is principally known as the primary organ of respiration. So the next outline we shall be discussing is the location. The location. Where is lungs located? The lungs, since it's a paired organ, is located at the thoracic cavity, particularly the right and left compartment of the thoracic cavity. You get, where it is situated and covered by the pleural sac or the pleura, because the pleura is a fibrous sac that covers the lungs, or a sac-like sheet that encloses the lungs at the thoracic cavity, particularly the right and left thoracic cavity, because the thoracic cavity is divided into three compartments: the right and left lateral compartment and the central compartment or the middle compartment. So the lungs, there is two of them, occupies the right and left lateral compartment of the thoracic cavity. So it is located at the right and left lateral compartment of the thoracic cavity. So that is the location of the lungs. You get. Now, you have to understand that based on physiological concept, that is physiologically, the lungs is known as the organ for exchange of gases. That is the number one cardinal function of the lungs. That is cardinal physiological function of the lungs. You get it is responsible for exchange of gases, carbon dioxide and what and oxygen. You get in the blood capillary. So that is one of the cardinal physiological function of the lungs. The next we shall be discussing is the color. The color. Yes, the lungs has a color. You get. You have to understand that a newborn and people that stays in a clean environment, you get, their lungs is usually rosy pink in color. Rosy pink in color. Rosy pink in color. This is for people that stay in a healthy environment and in a newborn. Their lungs is usually what? Rosy pink in color. Why for those that stays in a polluted environment and smokers, their lungs is usually brown or black in color or have a mottled appearance because of the inhaled carbon particles. So this is for newborn and people that stays in a clean environment. Why brown and black in color are for those that stays in an for those that stays in a polluted environment and for smokers. For smokers. And also mottled appearance. Mottled what? Appearance. Get. This is for smokers. You get? Now brown and black and mottled appearance are for smokers. While rosy pink are for newborn and people that stays in a clean environment. So that is the variations on the colors of the lungs. You get. The next is the weight. The next is the what? The weight. You have to understand that we have two lungs and both of them have different weight and structure. Now pay attention. This is right lung. Left lung. You have to understand that they have different weights and the general structure, but perform same function. Yes. But they are fashioned differently on their structure, but they have a unique and a unified function. Now, the weight of the right lung is quite different from the weight of the left lung. The right lung weighs 700 grams, while left lung weighs 650 grams. So these are their what? Their weights. You get? These are their weights. Get? So the next we shall be discussing is the anatomical position and site determination of the lungs. And anatomical position and site determination of the lungs. So anatomical position and site determination of the lungs is what we shall be looking on to. Now see it here. Number one, Number one, number one is that the conical long apex, the conical long apex is usually directed upward. These are how to know that yes, this structure is a lung. Its anatomical site determination and position. Number one is that the long apex, this is the long apex. The long apex. So the long apex is conical and it is directed upward towards the root of the neck. This is what conical and directed upward towards the root of the neck. While the base, you get, is directed downward towards the dome of the diaphragm. You get, it rests on the dome of the diaphragm. You get. Now this is the base. This is the base. That is the base of the lungs. That is the number one determination of the lungs, is that the conical long apex is directed upward towards the root of the neck, while the base is directed downward. You get, towards the dome of the diaphragm. The number two is that the convex costal surface of the lungs is always directed outward. It's always directed what? Outward. That is the costal surface. While the flat medial surface is always directed what? Inward. The flat medial surface presenting hilum is always directed what? Inward. That is another feature we use to determine the lungs on its anatomical position and side determination. Yet we talk about their surfaces. Get, the convex costal surface is directed what? Outward. While the flat medial surface presenting hilum is always directed what? Inward. Now, the number three feature on the anatomical position and site determination of the lungs is that the margin, that is the anterior margin, is always directed forward. The thin margin, that is its anterior margin, is always what? Directed what? Forward. You get. While the rounded posterior border, is always directed backward. So that is the anatomical and side determination of the lungs. You get. So the next we shall be discussing is the external features of the lungs. External features. We have the apex, the base, we have borders, surfaces, fissures, and lobes. So these are the external features of the lungs. We'll talk about the apex, the base, the borders, the surface, fissures, and the lobes. Now let's start with the apex. This is the apex. The apex of the lungs, or the lung apex, is rounded. It is rounded or conical. So the lung apex is rounded and conical, which is the blunt superior end of the lungs. It is rounded or conical, which is the blunt superior end of the lungs, which is directed upward towards the root of the neck. You get. And it is 3 cm superior to the anterior end of the first rib. It is 3 cm superior to the anterior end of the first rib, and 2.5 cm to the medial to third of the clavicle. You get. And this lung apex, or the apex of the lungs, is usually covered by the cervical pleura and the suprapleural membrane. You get. It is usually covered by the cervical pleura and the suprapleural membrane. So that is all about the lung apex. This lung apex also has relation. Yes. It has relation. The apex of the lungs, it has relation, anterior relation and posterior relation. Now, the anterior relation, you get, anteriorly, it is related to some structures, you get, such as the subclavian artery, the internal thoracic artery, and the anterior scalenus muscle. You get. Those are the structures that it is related to: the subclavian artery, the internal thoracic artery, and the anterior scalenus muscle. Now, the posterior relation, it is related to the neck of the first rib and the structure that passes on it, such as the ventral rami of the first thoracic nerve, the posterior and the first posterior intercostal vein, the first posterior intercostal artery, and also the sympathetic chain. So those are the structures that passes along the neck of the first rib, which forms the posterior relation of the apex of the lungs. So recall that I said previously that the apex of the lungs is covered by the cervical pleura and the suprapleural membrane. Now pay attention. Those structures that are related to the lung apex are separated from the lung apex by the suprapleural membrane. You get? They are being separated from the lung apex by the suprapleural membrane. And you have to understand that the lung apex is being grooved by the subclavian artery on its medial aspect and also in front of it. You get? Because the lung apex is grooved by the what? Subclavian artery on its medial aspect and in front of it. But all those structures are separated from the lung apex by the suprapleural membrane. Now, that is where we come about the Pancoast syndrome. The Pancoast syndrome the Pancoast syndrome. Yeah. Now, the Pancoast syndrome occurs as a result of the compression of those structures that forms the posterior relation of the lung apex due to the lung apex cancer, that is the cancer of the lung apex, you get. And once there is a damage to those structures that forms the posterior relation of the lung apex by the cancer of the lung apex, it will result to what? Pancoast syndrome. And what are those symptoms that will be implicated? You get, or other pathology that will be implicated? We have the Horner syndrome. Because why is Horner syndrome implicated? Because there is an involvement of the sympathetic chain. You get, because the sympathetic chain is one of those structures that forms the posterior relation of the lung apex. Another thing is that there will be pain along the medial side of the forearm and the hand, and also damage of the small muscles around the hand, because there's an involvement of the ventral rami of the first thoracic spinal nerve. So that is how it does what? It works. That's what we talk about the Pancoast syndrome, because of the involvement of the structure that forms the posterior relation of the lung apex, because of the cancer of the lung apex. Yeah, that is it. Okay. The next we shall be discussing is the base. The base. This is the base. This is the base of the lungs. The base. Now, the base of the lungs is directed downward. You get it is what directed downward. It has a semilunar concave surface which rests on the dome of the diaphragm, often regarded as the diaphragmatic what surface. So that is all about the base of the lungs. It rests on the what? On the dome of the diaphragm. You have to understand that the base of the right lung is more deeper or more concave. It is more deeper or more concave because the right dome of the diaphragm is way more superior because it accommodates the liver. So because it accommodates the liver, it is now seems that the base of the right lung is more concave or deeper because of the liver. It accommodates the what? The liver. And the liver is more bigger on the right aspect compared to the left. You get? So it accommodates it. That is why it is more deeper or more concave compared to the base of the left lung. Why? Because the right dome of the diaphragm is more superior so that it will accommodate the liver. That is an important clarification to note about concerning the base of the right lung and the what? And the left lung. So let's discuss the borders. The borders. The lungs has three borders. We have the anterior border, have the posterior border, and we have the inferior border. Now let's proceed. Now watch here. This is the anterior border of the lungs. Anterior border. This is the posterior border. While here is the inferior border. Now, the anterior border of the lungs is thin and short compared to the posterior border. It is thin and short compared to the posterior border. Now, the anterior border of the right lung is vertical. It is vertical. The anterior border of the right lung is what? Vertical. You can see it. It is vertical. This one is not that vertical. We are still coming to it. Like the left lung is not vertical. It is only the anterior border of the right lung is vertical. While the anterior border of the left lung presents a wide notch known as the cardiac notch. Here is the cardiac notch. This is the cardiac notch. Cardiac notch. You get? Because the anterior border of the left lung present a wide notch known as the what? The cardiac notch. Now, the cardiac notch accommodates the heart apex and the pericardium. It accommodates particularly the apex of the heart and the pericardium. You get? That means on the region of the cardiac notch is where the heart and the pericardium is uncovered by the lungs. That is why it is responsible for the area of superficial cardiac dullness. You get? The area of the cardiac notch is responsible for the superficial cardiac dullness because the heart and the pericardium is uncovered on the region of the cardiac notch. And below or inferior to the cardiac notch presents a tongue shaped projection known as the what? The lingula. Here is the lingula. The lingula is a tongue-shaped projection that is inferior to the what? To the cardiac notch. We have superior lingula and inferior lingula also. So that is all about the anterior border. Now, on the posterior border is thick and rounded. You can see it is what? Thick and what? Rounded. You get? It is thick and rounded. It is an important what? Border. And it extends from the seventh cervical vertebra. You get? It extends from the what? From the seventh cervical vertebra to the fifth thoracic vertebra. So that is how it extends. I mean to the 10th, not the 5th. It extends from the C5 to T10. You get? So this is the extent of the posterior border from the 5th cervical vertebra to the 10th thoracic vertebra. So that is it. Okay. Now the inferior border of the lungs is the lower border, and it has a semilunar surface. You get? It has a what? A semilunar surface. It separates the costal surface from the medial surface. So that is all about the inferior border. Now, the next we shall be discussing is the surfaces. The surfaces. The lungs has two surfaces. Two surfaces. It has two surfaces. You have the costal surface and the medial surface. So the lungs has two surfaces, the costal surface and the medial surface. Let's start with the costal surface. The costal surface. The costal surface of the lungs is what? It is large, smooth, and convex. It is large, smooth, and convex, and is covered by the costal pleura and the endothoracic fascia. You get? So it is large, smooth, and convex, which is being covered by the costal pleura and the endothoracic fascia. So that is all about the costal surface of the lungs. Now let's deal with the medial surface. The medial surface of the lungs is divided into two parts. We have the anterior large mediastinal surface and the posterior small vertebral surface. The anterior large mediastinal surface and posterior small vertebral surface. So these are the two subdivisions of the medial surface. Now, the anterior large mediastinal surface is talking about the surface that are related to the side of the mediastinum. You get? So it contains the lung hilum. It contains the lung hilum, which is an area in which structures enters and leave the lungs. A lung hilum is an area provided on the mediastinal surface in which structures enters and leave the lungs. So it is found on the mediastinal surface of the lungs, particularly the subdivision of the medial surface. Now, the posterior small vertebral surface is found in relation to the vertebral bone. You get it's found in relation to the vertebral bone, also the posterior intercostal vessels, and also the lesser and greater splenic nerves. So all those are the structures that are related to the vertebral surface of the what? Of the medial surface of the lungs. So that is it. That is how it goes. The next we shall be discussing is the fissure. The fissure. The lungs has two fissures, which divide the lungs into lobes, into three lobes, depending on the either the right lung or the left lung. Now, here is the horizontal fissure of the lung. Fissure of the lung, while this is the oblique fissure. Oblique fissure. Here is oblique fissure. Now, you have to understand that the right lung has two fissures, while the left lung has one fissure, which is the oblique fissure. Whereas in the right lung, we have the horizontal fissure and the what? Oblique fissure. You get. Why does the left lung has one fissure? Because of the what? The cardiac notch. So the left lung has to accommodate the lung apex. I mean the cardiac apex. You get. That is why it has one fissure and two lobes. While the right lung has what? Three lobes. Now on the lobes, the right lung has three lobes. We have the superior lobe, or the upper lobe. We have the middle lobe, and we have the inferior lobe or the lower lobe. Why the left lung has two lobes, superior lobe and inferior lobe. This is our trachea. So that is how the lobes and fissures of the lungs are fashioned. You get. The right lung has three lobes: superior lobe, middle lobe, and inferior lobe, and two fissures: horizontal fissure and what? An oblique fissure. Why the left lung has two lobes, the superior lobe and the inferior lobe? It has one fissure, you get, which is the what? Oblique fissure. So that is all about it. Now, the next we shall be discussing is the root of the lung. The root of the lungs. The root of the lungs. What is the root of the lungs? The root of the lung is a short, broad pedicle connecting the medial surface of the lungs to the mediastinum. It consists of those structures that enters and leave the lungs at the lung hilum. That is all about the root of the lungs. Okay. It is a short, broad pedicle connecting the medial surface of the lungs to the mediastinum, consisting of those structures that enters and leave the lungs at the lung hilum. Okay. So that is all about the root of the lungs. So the lung hilum. The lung hilum is an area on the mediastinal surface of the lungs through which structures enters and leave the lung. That's all about the lung hilum. Now let's show the differences you get between the adult and fetal lung. difference between adult and fetal lung. One thing you should understand is that lung does not work in the intrauterine life, that is the life in the womb. Lung is always inactive in the womb. That is why the placenta plays the role of the lungs in the womb. Now, the adult lung is spongy in texture. It is what? Spongy in texture. And it can crepitate because it contains air on its alveoli. Why does it crepitate? Because it contains air in the alveoli. That is why if you place an adult lung in the water, it will float, it will not sink because there is a presence of air on its alveoli. You get? And that is why it can crepitate. But a fetal lung or a stillborn lung or a stillbirth lung, their lung does not contain any air in the alveoli. You get? And they cannot crepitate. And if you place them on water, it will sink because there is no air in the alveoli. You get? So it can sink on water and it does not crepitate. So you have to understand the differences between the adult lung and the fetal lung. The adult lung cannot sink in water. It will float because of the presence of air in the alveoli. And it can crepitate. You get? And it is spongy in texture. But for fetal lung or stillborn lung, it does not do that way. The reverse is the case because they can sink on water because they do not have any air in the alveoli. You get? So that is how it does what? It works. So the next we shall be discussing now is the blood supply, the lungs. Blood supply. The lungs is being supplied by two principal arteries, the bronchial arteries and the pulmonary arteries. Now, the next is the venous supply. The lungs is being drained by two principal veins, the bronchial veins and the pulmonary veins. Bronchial and pulmonary veins. So those are the venous drainages of them. You get? Recall that the right and left bronchial veins drains in the azygos vein and hemiazygos veins or superior intercostal veins. You get? So now let's dive into other area that we shall be discussing. The next is the lymphatic drainage. The lungs is being drained by superficial lymph vessels and deep lymph vessels. The lungs is drained by superficial lymph vessels and deep lymph vessels. Okay. All these lymph vessels drains into the what? The tracheobronchial lymph node and finally into the bronchomediastinal lymph node. You get? They drain two of them, the lymph vessels, both the superficial and deep, drains into the tracheobronchial lymph node. While the tracheobronchial lymph node finally drains into the bronchomediastinal lymph node. So that is how it does what? It works. You get? From the tracheobronchial lymph node to the bronchomediastinal lymph node. Now, the next which I'll be discussing is the nerve supply. The nerve supply. The lungs is innervated by a parasympathetic and sympathetic fibers. You get that is what that innervates the lungs. So it's innervated by parasympathetic and sympathetic nerve fibers. You get, and you have to understand that the parasympathetic nerve fibers is the vagus nerve. You get the vagus nerve. Why the sympathetic fibers is coming from the T2 to T5 thoracic spinal nerve. The T2 to T5 thoracic spinal nerve is the sympathetic nerve fibers from which innervate the lungs, while the vagus nerve is the parasympathetic. You get, I have to understand that this nerve provide motor innervations to the smooth muscles of the bronchial tree, and also innervate or provide a secretomotor supply, you get, to the mucous gland in the bronchi. You get, they provide a what? A secretomotor supply to the mucous gland in the bronchi, and also provide a motor supply to the smooth muscles of the bronchi. So that is their work. First is a motor supply to those smooth muscles. Second is the what? A secretomotor supply to the mucous gland in the bronchi. That is how it works. The next is the clinical relevance. The clinical relevance of the lungs. Clinical relevance. Number one is bronchial asthma. Bronchial asthma simply means the spasm or the tightening of the smooth muscles in the bronchi. You get, it is being caused by certain triggers. You get, it is the tightening or the spasm or the bronchospasm of the smooth muscles of the bronchi. That is what that is known as the what? The bronchial asthma. The number two is emphysema. Emphysema is one of the chronic diseases, chronic obstructive disease of the lungs. You get, whereby there is a destruction of the alveolar sacs in the lungs. You get, where there will be a difficulty in breathing. You get, so it's a problem of the alveolar sac in the lungs. Call it what? Emphysema, pulmonary emphysema. The number three is lung tuberculosis, which is TB. Lung tuberculosis is a bacterial infection of the lungs. It is also a deadly pathology of the lungs because it presents numerous symptoms such as coughing and all that. The number four is pneumonia. Pneumonia, you get. And pneumonia simply means what? Accumulation of air on the lungs. You get accumulation of air on the lungs. Number four Number 5, we have pulmonary edema, which is wet lung. Pulmonary edema, which can be called wet lungs. Wet lung. It is an accumulation of fluid in the lungs. You get accumulation of fluid in the lungs. That is why it's called wet lung. And there are numerous pathology that, or numerous etiology that causes it. You get. I believe we have done justice to the anatomy of the lungs. My next class, I will treat the root of the lungs, the lung hilum, and bronchiopulmonary segment. I want to I want to appreciate you all for staying to the end of this class. We have digressed it from the introduction to the clinical relevance. Thank you so much for staying to the end of the class.